Hello and welcome back to ACCRAC. I'm Jed Wolpaw and I am really excited. We have a fabulous show for you today. I've got two awesome guests who are really experts in what we're going to talk about today, which is optimizing PEEP in the ICU, really trying to optimize the open lung, trying to keep patients' lungs open, avoid atelectasis, and really try to find the ideal PEEP for patients in the ICU. It's a much more complex topic than I think a lot of people realize. I think a lot of our residents these days just kind of assume there's maybe normal PEEP, which might be 5, and then maybe patients with lung injury might need some more PEEP. But there's a lot more subtlety to it. And I will say that we're going to focus on the ICU. This absolutely can apply in some different ways to the OR as well. So my first guest is Brandon Odo. Brandon has been on the show before, and I've been on his show. And we met way back when he was doing a critical care physician assistant residency program at Johns Hopkins. He is now a critical care physician assistant in the medical ICU at Bridgeport Hospital. He's a clinical instructor with the Department of Medicine at Yale School of Medicine. He did his residency, as I said, at Johns Hopkins, where we first met. He's since worked clinically in medical, surgical, trauma, and neurological critical care settings. He's chaired national committees within the Society of Critical Care Medicine and the Society of Point of Care Ultrasound. And he's authored numerous educational reviews and textbook chapters. He founded and co-hosts the popular educational podcast Critical Care Scenarios, which I was a guest on. They do a fabulous job. And he manages the educational blog Critical Concepts, and he teaches at the Online Intensive Care Academy. Really excited to have Brandon here with us. And my second guest is Thomas Piraino. Tom is a registered respiratory therapist, educator, and consultant. He serves as an adjunct lecturer for the Department of Anesthesia at McMaster University. In addition to authoring research papers, editorials, and textbook chapters, he is the editor of the Center of Excellence in Mechanical Ventilation blog, which is fabulous. He also serves on the editorial board of Respiratory Care. Tom and Brandon, thrilled to have you here on the show.
Excited. Thanks for having us.
So why don't we just start, each of you kind of give a little bit of an overview of what your day-to-day looks like. What are you doing in critical care, and what does that look like on a day-to-day basis? Brandon, you want to start?
Sure, yeah. Nowadays I'm in the medical ICU. In the past I did some other things. This is certainly a relevant topic in any flavor of critical care where you're involved in mechanical ventilation, which is all of them. But I think PEEP is just a fascinating topic because it's relevant, of course. You're always dealing with this when you're on the ventilator and perhaps off the ventilator. But I think it's also a great demonstration of respiratory physiology. I mean, if you understand PEEP in a subtle way, then you understand how the lungs work, and it ties into a lot of what we do, as well as maybe demonstrating a lot of the typical themes in critical care. For instance, does manipulating physiology improve the patient's outcome? If it does, do we have the data to show that? Are you just entertaining yourself, and so on? But I think it's interesting. Hopefully Tom agrees. And I think everyone can kind of pull out the aspects that are relevant to them, which depends on your patients, depends on what you have available as far as technology, depends on the diseases you see, and so on.
Fabulous. Tom?
Yeah, I agree with those sentiments. My day-to-day, so interestingly enough, I'm now exclusively education and consultant when it comes to my respiratory therapy work. I'm still involved with a lot of research projects, mostly like on the steering committees and protocol development, et cetera. I don't work clinically at the moment. And that, long story short, I started a business. It kind of took off. I had to leave the clinical stuff to do that, but it's actually freed me up for more of the education and consulting stuff. So my involvement with research actually increased after I left the bedside because I had more time to facilitate. So a lot of research reading, a lot of research participation, again, mostly remotely, and a lot of education, speaking at a lot of conferences. So I don't have a day-to-day, I have an obsession, more likely. So this is one of those topics that I've been obsessed with for over 15 years of my career in terms of, the optimal setting of PEEP. And, little bit of a spoiler alert, there isn't an optimal PEEP, but we'll get into that.
Fabulous. I look forward to it. All right. Well, let's start with asking the question of why we care. Can't we just put everybody on 5 a PEEP and won't they do just fine? I'm guessing the answer to that is no, or we wouldn't be here doing this podcast. So, guys, why does it matter how we set PEEP in the ICU?
I mean, I think it depends on the patient, and there are different factors that could play a role. For example, the hemodynamic impacts or anatomic considerations, like somebody has a pneumothorax or something. But mostly what we're concerned about is optimizing lung recruitment, in principle, it seems like the best lungs to ventilate will be sort of sitting at their FRC. That's kind of how we all live our lives. And why? Well, because we want to optimize oxygenation, which is more of a problem for some patients than others, but of course everyone needs to oxygenate, but also to manage a lung injury, right? And we sort of have this idea that if you mess up your PEEP, people are going to be more prone to lung injury, either because of adduct trauma. If you have cyclic recruitment and de-recruitment with each breath, pressure drops, a bunch of your alveoli flatten out, and then you give the next breath and you pop them open, you apply a lot of stress to them. But on the other hand, if you're over-distending and overinflating portions of the lung, that's not good for them either, right? You're stretching out those alveoli. So presumably, and this is sort of like Tom said, imaginary point, but we like to think there's some amount of pressure where you keep as much of the lung inflated as possible without overinflating it, and therefore minimize injury and optimize oxygenation.
Great. Tom?
Yeah, and I think... Yeah, for the purpose of the listeners, when I said spoiler alert, there is no optimal PEEP. My point is there's always the theoretical benefit of PEEP is that you minimize adduct trauma. That's really the goal, is that particularly when you sedate and paralyze a patient for the purpose of intubating, even if you just heavily sedate, you stop their spontaneous breathing. They're now no longer contributing to diaphragm contraction and their own lung opening and expansion. Now using the ventilator, the idea of PEEP is to help maintain some of the FRC that they would have had. Where you get with the compromise is that in some patients, there are regions, again, depending on lung severity, if you have a very sick patient with pneumonia, for example, some areas are less likely to open up with any given PEEP level, whereas you may easily over-distend other areas, and this is where the compromise happens. But I think in most healthy patients that are intubated, whether it's in the operating room or even post-surgery, a level of PEEP that maintains an open lung or helps prevent atelectasis is reasonable, and this is why we typically set most patients, we start at a minimum of 5, and I would argue 5 to 10 for most patients. But where it gets really complicated is once you get to those levels of 10 and higher, you all obviously run the risk of in an attempt to try to minimize adduct trauma, you obviously areas that are already open just because of regional differences, all of our areas up here, they're going to be open already. You're just potentially adding stress and strain to those areas. And this is where it gets complicated and why some of the PEEP studies that I'm sure we'll discuss, likely why many of them don't provide any evidence of benefit over one method versus another.
Yeah, I think it's actually really crucial for all these things we're going to talk about. We like to imagine the lung in this idealized way where it's one balloon or maybe a couple of them and we draw it on a whiteboard, but it's not, right? It's a population of a zillion little alveoli, and they all may be very different. And probably the more different they are, the harder it is to manage them because we can't ventilate them all separately. We can only apply one pressure at the head of the airway there. So I kind of see it more as like population medicine. It's like if you give one drug to everyone in the United States, will it help them? Well, probably some of them, others it will hurt. So we're kind of working with averages here. And that's really a kind of important thing to understand.
Yeah, I think that's super important. And there's so much variation just in general in the lung. And then, of course, from patient to patient and situation to situation. And so, there's certainly not one level, whether 5 or anything else, that you could park every patient at and be in the best scenario for that patient. So we'll definitely talk more about that. What about the ARDSNet table, right? So there is an ARDSNet table that tells you, kind of helps to guide your PEEP in a patient with ARDS to try to maximize their protection of their lung while also oxygenating a patient who might be difficult to oxygenate. Why isn't that something we can just use for everybody?
You could. The upside is that it's real simple, right? So I think this is the way to go for someone who's not going to be trying to tackle the physiology on some deeper level. People who are not doing critical care every day, maybe you're in the emergency department or in the field, something like that, because you will probably avoid the worst errors, which is to say having way too high or way too low of a PEEP. The downside is that it's a super blunt tool. I mean, all you're really doing here is titrating your FiO2 and your PEEP together, and therefore saying that if someone has very severe hypoxic disease, they both need a lot of FiO2 and a lot of PEEP, and if they don't, then they don't. And that is probably sort of true for most people, but those are not the same thing, right? I mean, if you have a a terrible PE and a right to left anatomic shunt, you may be quite hypoxic, but you're not going to respond to PEEP at all. I mean, that's an extreme example. But so in general, I like to try to look at a patient and to look at their actual physiology and how recruitable their lung is. And those pressures may or may not map to an existing table. Now, if you are a pure EBM kind of person, you could just say, this is what was done in some of the more compelling ARDS trials, like the original ARMA trial, for instance, and therefore that's what you'll do. And I don't know. I can't argue with that, I suppose. But it's hard to argue that this is why people survived.
Yeah, absolutely. And I think some of the tools that we'll discuss today were not around when the ARMA trial was done. And so, there are things evolve. And while one thing may have been the best option at a certain time, doesn't mean it always will be. So I think we'll think about that as we go through today as well. Tom, what do you think?
Yeah, I think we also have to consider the fact that those tables have become the gold standard and the comparator for almost every control arm of every PEEP study since. So despite there being new techniques, they've all been compared to that. And to date, we still don't have something that has been superior to that. And again, likely due to the fact that when you randomize a certain person to a certain type of PEEP titration, that individual person it may benefit them and it may be harmful for that person. And really, this is there's a benefit to randomized trials, but when you have unselected patients with different types of recruitment potential, for example, you're going to get patients on, as an example, a higher level of PEEP, where that would be the worst thing for that patient. And then you have the patient who needs the higher level of PEEP who got the lower PEEP setting, or again, depending on the comparison. But those PEEP tables have been compared, again, high versus low against each other. No difference in outcomes. In an individual patient meta-analysis in 2010, Briel and colleagues did do a meta-analysis showing that higher PEEP was favorable in patients with moderate to severe ARDS. But in more recent ARDS guidelines, that's, again, one group, I believe it's the ATS, says yes, still use higher PEEP tables for moderate to severe ARDS. And the European guidelines have now said we don't have sufficient evidence to argue higher versus lower strategy in these patients. And they also can't argue a strategy of using respiratory system mechanics over top of just a PEEP table because, again, we lack the appropriate evidence. And all of these guidelines suggest the fact that perhaps we need to look at other things to stratify patients, like recruitment potential as an example.
Yeah, and I do think that even if you think you are more clever than a table, which you may or may not be, it provides a good starting kind of pretest probability, meaning if you look at a patient who's on like 100% FiO2 and their PEEP is 5, you should have some pause because that would be a bit odd. Or if their PEEP is 25 and they're on 40%, those may be the right thing, but it is odd.
And the PEEP tables are generally like if you were to poll, all of North America at least, because these tables really born out of the ARDSnet group. So if you were to poll hospitals, I would argue that many of them would have these tables protocolized in their mechanical ventilation protocols. So if RTs have the autonomy, like respiratory therapists have the autonomy to make PEEP adjustments, typically it's within a PEEP table. And this is either ordered directly or it may be the starting point until a physician or someone writes an order for a specific PEEP level. But until that point, typically that guides us. Now, having said that, when they did the large epidemiology study, the LungSafe study over 500 ICUs in 50 countries, when they looked at patients that met criteria for higher PEEP, for example, or even within the PEEP table, even the low PEEP table, once you get to 70% FiO2, you're on PEEPs generally higher than 10, like 10 and higher. And the majority of people don't ventilate patients on those appropriate PEEP levels. So despite there being evidence that, nothing is better than this, as of yet, and this was used in large trials and therefore is a gold standard, we still don't adhere very well to those PEEP tables, despite the idea of that's the simplest way to do it, but we still don't even follow that most of the time.
Yeah, I think those are all great points. And Brandon, as you said before, we are, of course, going to think about the pathology and we're going to be thoughtful and we're not just going to blindly follow a table. For example, the example you gave, a patient with a massive PE who's hypoxic, we obviously are not going to crank up the PEEP to 20 because they have really poor oxygenation, which would be a potential disaster and right heart failure. So we want to think about what's going on and not just follow it blindly. But I think the point that you're both making is also that when we're talking about a huge population, sometimes a basic evidence-based guideline is actually going to, on average, help people more than anything else. So while we take out those outliers of the massive PE or whatever else might be going on, we end up with a lot of people who probably will benefit from some reasonable amount of combination of PEEP and FiO2. All right, let's talk about some different ways that we can try to personalize PEEP and optimize PEEP for an individual patient. So compliance is something we talk about a lot in the ICU and the OR. Let's talk about that. What is compliance and how can we try to optimize it?
So to me, the role of compliance here, and compliance can play a role in other things, of course. Someone with, chronic interstitial lung disease will have poorly compliant lungs and stuff. But the real question here is using compliance as a marker for recruitment, which is to say, if you apply a fixed volume or a fixed pressure to the lungs to inflate them, if the lungs are very easy to inflate and have a very high compliance, then as a marker to titrate to, that suggests you've inflated a bigger lung than if it were the opposite. So if I give you a tidal volume of 500 cc's and let's say the plateau pressure that results is 15, then that is a more easily inflated lung than if the plateau pressure was 30. And that could be something about the lungs, but usually in diseases like ARDS that we're managing, what it really means is you didn't inflate very much of the lung. You have a large portion that is not being ventilated. And therefore, if we can change that, it implies that we've changed the recruitment. We've opened up a portion of the lung that was previously not, and the effective lung volume is now higher. So using compliance as a marker for recruitment is kind of a way to biopsy the lungs, to look into how much you're actually filling with air in a way that may be hard to do without X-ray vision otherwise. Now, how you do that depends on a lot of variables, but that's sort of the general idea. And I think that's an important way to think about it because, compliance is also important for things like lung injury and so on. But here it's kind of being used as a marker for just the lung size, basically.
Yeah. So in other words, we're talking about, I think it's a very easy concept for people to understand. Basically, if you give a certain amount of pressure to a very compliant lung, you're going to get a lot of volume for that given amount of pressure. If it's a not compliant lung, you're not going to. And you could just think about this as I know we want to get away from the balloon analogy, but for this purpose of this, right? If you have a very stiff balloon, you're going to have to blow really hard to get it to expand. If you have a very loose, compliant balloon, you're going to be able to blow into it, and you're going to get a lot of air in there. And so the more compliant the lung, the more expansion you'll get for a relatively lower amount of pressure. So compliance seems like something we would want to optimize. We want the lung to be compliant. And when we have a lot of collapse, right? When we have a lot of atelectasis and the lung is collapsed, then it's not going to be compliant because you have to push hard to open that up. And also when the lung is over distended on the other end of things, right? If you already have full lungs, you're not going to be able to get much more in there and they're not going to be compliant. So somewhere in the middle is that compliance.
Well, and I think the easy way to get confused is to think of something like ARDS as a disease where your lung tissue is less compliant, which is actually not right. We think of them as stiff lungs, but unless it's super advanced and they've become fibrotic or something, the reason they seem stiff is because you're inflating a small portion of them. You're inflating this little baby lung and the rest is collapsed. But that's a moving target. If you can inflate that lung, it will appear more compliant.
Right. Yeah. So, Tom, anything to add there?
Yeah, just compliance is a really confusing respiratory system mechanic. It's extremely important. It's the element behind driving pressure, which I'm sure we'll get into, but essentially using, tidal volume divided by respiratory system compliance gives you driving pressure. Mathematically, it's the same as plateau minus PEEP, which is the denominator in the mils per centimeter of water of compliance. But really it tells you, again, the unit change in volume it's the change in volume per unit change in pressure. So obviously a more compliant lung, when you add centimeters of water, it's going to add more volume to your patient. And in fact, you can predict how much volume you're going to add, end expiratory lung volume, for example. If you had a PEEP of 5 and your compliance is 40, if you change PEEP by 10, let's say you go up to 15, well, 10 times 40 is 400. You're going to add 400 mils to the end expiratory lung volume. Now, what you hope, ideally, is that 400 mils improves a reduced FRC. But in a patient who doesn't have a reduced FRC, or you can't open the lungs, they're non-recruitable, that 400 mils gets added to the numerator of a strain equation, which is the amount of volume on top of FRC. So this is why it gets super complicated. But compliance itself is also a bit tricky. When we've done a multiple number of EIT studies now, and what we're finding is that the optimal respiratory system compliance often correlates with a increasing degree of collapse that is occurring. Now, what you're finding is that there's tidal recruitment, so it's not reflected. The compliance looks like it's getting better and better. There's tidal recruitment, so it's not so much atelectasis that is not recruiting. It's the fact that it's opening and closing. And that opening and closing is not being reflected in the respiratory system compliance. So it's tricky. We think we should go by the best compliance out there, but that's often associated with collapse. So there's likely some underlying injury that could be occurring. So what level of compliance do we choose? Do we choose the best compliance? Do we choose the best +2? And this has been the way that it's been protocolized over the years, doing a decremental PEEP titration. You start at a high PEEP and you monitor respiratory system compliance as you decrease PEEP slowly. This is one PEEP titration method. But as you're watching compliance, the question is, do you wait until the compliance is the best it possibly can? Typically, we used to do that and then go +2. The reason being is that CT studies had shown that at the highest compliance, there were areas of collapse. EIT studies are showing the exact same thing, that at optimal compliance, you have more collapse. So whether it's best compliance +2, all we know right now is that all of the studies that have utilized compliance in a decremental PEEP trial have either been stopped early for futility or showed harm, like the ART trial that had over 1,100 patients in it. Now, they did include an aggressive recruitment strategy, which we can probably get into. Like, do you bother recruiting the lungs before trying to set PEEP? And this is controversial now. And the ARDS guidelines have sort of turned away from it, highly due to this study, this ART trial that was published. But really, the idea of compliance, it makes the most sense, right? If you have a nice, easy to inflate lung, it must be the safest way to ventilate. But to date, we still don't have the evidence that it is the best target. But it could be muddled by the fact that we have, or muddied or whatever. The waters are muddy by the fact that we had aggressive recruitment strategies, et cetera.
Yeah, part of what this gets at is we're balancing both best oxygenation and also minimizing lung injury. One of those we can evaluate at the bedside because we can watch the oxygenation. You can't really evaluate lung injury. You got to do a study for that, right? You got to see kind of where their outcomes end up. So I think we always are going to tend to believe in the things that makes like the SAT go up. But
yeah, no, unfortunately, that's what
the patient.
Yeah, that's what 12 mils per kilo did, right? Like the original ArtsNet 12 versus 6 mils per kilo. The 12 mils per kilo group, if you look at the data, they had better oxygenation and better gas exchange. So their pH was better, CO2 was better, oxygenation was better. They had better oxygenation through the first 3, and I think even at day 7. But they had higher mortality. So I mean, since that publication, we've known that oxygenation, although it can be correlated to good outcomes, it's also not a good indicator of good outcomes because we have evidence that when oxygenation is better, things can also be worse. Another example of that is the Oscillate trial, right? The oscillator versus high PEEP table. There was less refractory hypoxemia, better oxygenation in the HFO group. The study was stopped early due to harm from the HFO. So we have more and more studies that, perhaps over-distending a lung could possibly increase oxygen. There's mechanisms for that. You can change your shunt, which would have your oxygen go up, even though it's not perhaps beneficial for the lung. So as you said, Brandon, we can't assess lung injury. So we look at a SAT and we go, oh, this must be better because oxygen is going up. Meanwhile, while the oxygen is going up, we're potentially causing injury to the lung that eventually will come around and display itself in other ways like multi-organ system failure rather than just the lung issues that we're having.
Yeah, these are all great points. And so when we talk about, I want to go back to something you said, Tom, which was, and maybe we should just lay this out. If you're going to do a decremental PEEP trial, tell us how that's traditionally done. And then you said, okay, maybe there's some thought that if you find quote unquote ideal PEEP where compliance is maximized, you want to go up by 2. And you meant up by 2 on the PEEP from whatever that PEEP was?
Yeah, that was one of the traditional protocolized ways of doing it. Yeah. So with the decremental, the decremental PEEP trial was actually the first PEEP titration method that I got, again, for lack of a better word, obsessed with as a younger RT. There was a study published in Respiratory Care, and it was just sort of displaying the method and the change in oxygenation and gas exchange. Dead space fraction was measured at different PEEP levels, and it was actually quite a fascinating study. And it really got me interested in like, okay, we're just using PEEP tables at the hospital I was working at. What if we found this other way? What if we titrated PEEP according to this decremental PEEP trial? So then it came down to, okay, you're going to start at a higher level of PEEP and come down. Then the question is, do you try to recruit the lung with a higher pressure prior to doing this? And originally that was exactly the method. Essentially, you do a lung recruitment maneuver. And for some people, that would have been 35 for 30 seconds or 30 for 30 or 40 for 40. I always argued that 30 for 30 had been shown in studies not to do essentially anything. If you're trying to recruit or pop the lungs open, you need to exceed pressures that you're typically ventilating at. And, keeping your plateau less than 30 with ARDS patients, that's not a recruitment maneuver. So most people were using 40 for 40. The Loves trial used 40 for 40 for recruitment maneuvers. The HFO oscillator study also used 40 for 40. So, we have this idea of maintaining a pressure of 40 centimeters of water sustained over time to pop open areas of the lung. Then you start at a higher level of PEEP. You ventilate at that PEEP level for, again, protocols were different, 1 minute, 2 minutes, some were 5 minutes. I used to argue that if 2 minutes is sufficient, use something like that. The longer you make it, the more you're standing at the bedside for a very long period of time. To go from a PEEP of 24 or 20 down to 5, going every 5 minutes, you're in that room forever. And it's just not feasible, right? So it's something that 1 to 2 minutes typically was written into a protocol, and you go down by 2 to 3 centimeters of water.
And the whole idea of doing this decrementally is that it's faster, because pressure and time always are a balance in recruitment. You can recruit at a higher pressure very quickly or at somewhat lower pressures with much more time. But de-recruitment is fast. You drop below that collapsing pressure for a certain balloon and it flattens out. So if you start high and go down, you should be able to pretty quickly see when compliance changes and some de-recruitment occurs. Whereas if you go up, then you would need to wait much longer at each point because you got to wait for recruitment.
Yeah, recruitment takes more time. De-recruitment is definitely much faster. I believe studies have shown 1 to 2 minutes, and like 90% of the de-recruitment that's going to happen is going to happen. Now, that's assuming you're not going to move the patient all of a sudden. So if you do this maneuver and then nursing comes in, does a full bed bath and flipping the patient all over, this is obviously going to completely change where your optimal PEEP might be, particularly when position changes. But in all, just to get back to the decremental PEEP trial, that was typically how it was done. So then people moved from this sustained inflation recruitment maneuver to a pressure control style recruitment maneuver. And this is where studies calling it the maximum recruitment strategy were published that showed really incredible results, again, in physiology studies with patients showing that you could essentially reduce ARDS in some patients just by maximally recruiting them and then setting an optimal PEEP level using a decremental PEEP trial. And what this method entailed typically was setting a fixed pressure control level of 15 and then starting at a PEEP of 25. So 25 and 15, you're hitting your 40 centimeters of water. But then you would do that for a minute or two, and then you'd increase it by 5 centimeters of water. So now you're at a peak pressure of 45. And then you'd increase it again to a maximum of 50. Now, the ART trial, the criticism that it received is that it did this style of recruitment maneuver going all the way up to 60 centimeters of water. Now, they changed the protocol after 3 cardiac arrests in the experimental group, and they changed it. They brought it down to 50. There was no difference in the outcomes of the patients that were after the protocol change versus before. And again, the outcome of that trial was that doing this recruitment maneuver and decremental PEEP trial was harmful compared to just regular PEEP table mechanical ventilation, which, again, likely the recruitment strategy had something to do with it. But the argument towards the pressure control styled recruitment, assuming you're not going up to 60, but just hitting 40, I would argue that I've done that many, many times on patients in my clinical practice, that recruitment maneuver. It is much more tolerated. So if you are doing the 40 for 40, if you work in a hospital that does 40 for 40 routinely, I highly recommend a PEEP of 25 and pressure control of 15 to more gently open the lungs than just a maximum of 40 the entire time. Hemodynamically is tolerated way better. You don't get huge drops in saturation like you would in some patients when you're at 40. So yeah. Overall, it was more tolerable, but the entire protocol, again, in a evidence-based study, we now have evidence to suggest that that's harmful, but it could have been the aggressiveness of the recruitment maneuver.
Yeah, and maneuvers in general are sort of, I mean, it's very rare that you need to recruit someone right now. Occasionally, you have some crazy sick ARDS patient, someone tripped over the tubing and disconnected them and they desat to 40 or something. I mean, it can happen, but usually you have time. And so, I mean, now we have this trial suggesting that doing aggressive maneuvers actually worse. I mean, how often do we have proof that something is bad for people? I think it's just, by and large, we can recruit people more with time than pressure. There are probably niche cases where... I think you should bear in mind that if people desat, you take them off the vent and you bag them by hand, you are recruiting them. I mean, that's largely what we're doing.
Put a pressure manometer on there. I'll tell you.
The fact that you're not watching on the ventilator doesn't mean that you're... So, I mean, we should say that is still happening, but...
And when we are doing this trial and we're coming down, we are looking at compliance and also driving pressure, which you brought up before, Tom. So do we need to look at both? Can we just look at driving pressure, which is quite easy to calculate, as you said, by just doing plateau pressure minus PEEP and seeing where we minimize driving pressure? Or do we need to look at both compliance and driving pressure? How does that work?
I think it depends on which method you're using. If you're using pressure control during your decremental PEEP trial, then essentially you have a fixed dynamic driving pressure. Your static driving pressure may change as you come down, but typically you're just monitoring respiratory system compliance either as measured by the ventilator or you're looking at tidal volume because your pressure is not changing. If you are using volume assist control, then because your volume is not changing, you would pay attention to your drive. You could just use driving pressure because if your volume is not changing, the only part of the compliance equation that would be changing would be plateau pressure minus PEEP. So you could look at driving pressure at each stage. Most people were just assuming respiratory system assuming resistance wasn't changing a lot during your titration. Most people would just go by dynamic compliance. But if it's possible your resistance could change, then you would need to do plateau pressures at each maneuver. In most studies, they're a lot more particular. They're actually measuring tidal volume, measuring plateau, measuring set PEEP or total PEEP, and then calculating respiratory system compliance. Either way, you're looking for... Again, if you're using pressure control, you can go by tidal volume essentially. But if you want to be quite specific to this protocol, you would calculate respiratory system compliance, which requires a plateau maneuver regardless of what mode you're using. Plateau minus PEEP again, and then the tidal volume that you're seeing ventilated.
I always, I'll titrate up incrementally quickly just to make sure they tolerate it hemodynamically. I'll go to a max that based on kind of my gestalt for their disease. How recruitable do I think they'll be? Give them a few minutes, go down in steps of maybe 2, and then at each point measure a plateau. And I usually just write this on like the whiteboard in the room, driving pressure at each level. The compliance I just never got in the habit of doing. Most of the events will calculate it for you. That's certainly fine as well. But I mean, what I find, and Tom, you can tell me clinically your experience. Some patients, you get a clear inflection where they have their best driving pressure or their best compliance. And you're like, oh, well, that's their best PEEP. More often, there's kind of a range where it's the same compliance within there. And then outside that range, it's clearly worse. Like if it's really high or really low. And that's still useful to me, especially at the extremes. It's like maybe that patient who's on like 20 of PEEP and they have like a clear chest and you're like, I don't think they need hardly any PEEP, but it's hard to know that for sure. And you're like, oh, well, their compliance is just better and better the lower I go. Like I think that's useful data. Expecting anyone else to be like, oh, this patient clearly must be on 12, not 14 of PEEP. That's probably a bit much, but it's still kind of a useful tool. As long as the patient tolerates it, as long as they're pretty passive. If they're breathing a lot, you're not going to get good numbers. But, it can be a tool, I think.
Yeah, ideally you have to consider the pressure volume curve. So a pressure volume curve is a compliance curve. It's mils per centimeter of water. It just represents compliance. And then we're typically taught that in open lung, you have a linear pressure volume curve, right? So if your pressure volume curve is linear, then you have many PEEP steps where your compliance is actually consistent. So it's the linear relationship. So yeah, you'll have a PEEP of 15 or let's say 14. We don't use odd numbers, right? Respiratory therapists hate odd numbers. So let's say you're at 16, you go to 14, driving pressure is the same. You go to 12, driving pressure is the same. It just means you're in a linear part of the pressure volume curve. Then once you get too low, again, whether or not you have de-recruitment or you have airway closure that's starting to occur, either way, your driving pressure changes because there's now an inflection or a bend in that pressure volume curve. Same when you're you're going up, your driving pressure all of a sudden goes up because it's harder to get the volume in. So there's a change in your pressure volume curve. So it is very common for you to have many PEEP steps where, not many, because you're going by two, you might have 2 or 3 that are almost unidentical. And you could argue that, okay, I'm in a linear part here. Maybe I'll just go to the lowest one where it's the same. And then if it goes up or down, again, as I mentioned earlier, sometimes the compliance going up, it could mean that you have more collapse in tidal recruitment. It gets kind of confusing because now you're sacrificing a little less over distension, but now you have the tidal recruitment. So the question is a little bit more over distension okay with a little less, adduct trauma or what? But to get to your point, yeah, you'll have many PEEP steps where it's the same, and you just have to decide what you want to do, but essentially it's telling you you're in a pretty stable part of the pressure volume curve.
Yeah, and the other caveat here, and Tom could talk much more about this, is that we think that we're measuring the driving pressure as, the plateau minus the PEEP, but in fact, the floor may not be the PEEP. It could be a point of airway closure, where we're no longer communicating with the alveoli, and you have some of your airways that have just shut, and you've lost that movement of air. And in that case, your sense for the compliance is going to be altered because we're not measuring what we think we are. And airway closure is not derecruitment of alveoli. You could sort of think of it as derecruitment of the airways, which is not a thing, but they're closing. And perhaps we should be trying to avoid that as well, in which case I guess your numbers still sort of work here, but it is a different phenomenon. And Tom's done a lot more work with this, but it's sort of a confounding factor. And if you really want good numbers, you should probably check for airway closure as well.
Stay with us. We'll be right back. Hey folks, if you've ever been listening to a patient's heart and lungs in pre-op and wondering if there's some mild wheezing or a faint murmur, you are not alone. I used to struggle with this all the time until I got my echo. Honestly, listening through an echo is like night and day compared to a regular stethoscope. That's because Echo's digital stethoscope amplifies heart and lung sounds up to 40 times, and there's noise cancellation to cut out distractions. I can't emphasize enough how amazing it is when you can hear so clearly. And you can unlock murmur and AFib detection powered by Echo AI, along with sound recording and sharing for earlier diagnosis as well. Echo is backed by 4 million heart sounds and 8 FDA clearances for devices and AI algorithms. Those who use it are 2 times more likely to detect heart disease. I can't tell you how much better I can hear hearts and lungs in every area that I work with my Echo. I trust Echo so much that I worked with their team to create a special offer just for our listeners. Right now, you can get $50 off plus a free customizable chest piece cover at echohealth.com/ACCRAC. Your purchase is HSA and FSA eligible and may qualify for CME reimbursement. Plus, Echo guarantees you'll detect heart and lung conditions more confidently. If you don't, return it for a full refund. Go to echohealth.com/ACCRAC for $50 off plus a free chest piece cover. That's EKOhealth.com/ACCRAC. Hey folks, I want to dive deeper into something that I think can truly make a difference for healthcare workers. FIGS scrubs. Made for awesome humans, these are scrubs that have our needs in mind. They're durable, antimicrobial, and super comfortable, which matters when you're 10 hours into your shift. I love my FIGS, and let me tell you, my wife, a pediatrician, loves her so much that she's all FIGS all the time. That's all she wears to work ever since COVID. It doesn't matter if you're a dentist, a nurse practitioner, an anesthesiologist like me, or even a med student starting out. Investing in a couple pairs of FIGS is totally worth it. We're partnering with FIGS to get you 15% off your first purchase when you use code FIGSRX at wearfigs.com. And FIGS goes beyond scrubs, too. They've got shoes, underscrubs, and even jackets that will make the ever-present hospital AC seem like a thing of the past. And they come in a wide range of colors that will let your personality shine through. With back-to-school season upon us, it's the perfect time to stock up with some fresh outfits for the year, and FIGS just dropped a brand new collection of limited edition styles and accessories. If you're in healthcare or shopping for someone who is, you can get 15% off your first order at wearfigs.com with the code FIGSRX. That's wearfigs.com, code FIGSRX. Hey folks, summer is here, and if you're like me, you want to be outside enjoying the weather, not stuck inside shopping and cooking. Factor solves that problem for you with their chef-crafted, dietitian-approved meals that are ready in just 2 minutes, taking the hassle out of eating well. My kids think Factor tastes like restaurant food, and it really does. Even my 2 younger daughters, who are very picky eaters, are loving every meal we get from Factor. Some of their favorites are the chicken tikka masala and the chicken taco bowl, but they really love everything. And with 45 different meal options across 8 dietary preferences every week, you can also choose from smoothies, add-ons, breakfast, and more to keep you going all day. Honestly, I still eat them for the convenience, even if they weren't so delicious. But the amazing thing is that it's super fast and incredibly tasty. I wouldn't have believed it until I tried it. Enjoy more this summer. Get Factor if you want all the flavor and none of the fuss. Get started at factormeals.com/ACCRAC50 off and use code ACCRAC50 off to get 50% off your first box plus free shipping. That's code ACCRAC50 off at factormeals.com/ACCRAC50 off to get 50% off plus free shipping. All right, and we're back.
Yeah, that became my standard of practice during COVID. So I was bedside for essentially from 2020, the beginning of the pandemic. I was still doing research in Toronto with Laurent Bouchard's group. We started the Recruit study there, which was just published, I believe, last year or the year before. But right up until the end of 2022, I was working clinically, and that was my approach. Any hypoxic patient I had, or any patient with oddly high driving pressures that didn't quite make sense based on their overall presentation, I was immediately checking for airway closure first, because essentially what this will tell you is the minimum level of PEEP you have to achieve just to overcome collapsed airways. Then your driving pressure measurements become more accurate. So for those who use pressure volume curves routinely, and because their ventilator has this recruitment tool and they think, it's really cool, it's showing me an inflection point. If it shows you an inflection point, it is telling you that there is some airway closure likely than recruitment, because earlier studies of pressure volume curves show that even when you're adjusting PEEP above the level of inflection, if you see a lower inflection point, you always have de-recruitment. You should technically be in a linear part of the pressure volume curve if you're making PEEP changes above that inflection level, but they're finding de-recruitment at each step, telling you that the inflection point probably isn't telling you that the lungs are recruited or now open. It's telling you something else. So they were hinting at this isn't quite right. And then in more recent publications, just this year alone, we have a nice EIT study showing that when you have a progressive, a nice sort of mild inflection point, it just tells you have airway closure of different degrees within the lung, and they could be off about 3 or 4 centimeters of water. Whereas when you have a very sharp inflection point, most of your airway closure is similar in different regions of the lung. But either way, if you're using pressure volume curve, it does tell you a minimum place to start setting your PEEP, but it doesn't tell you that your lungs are recruited. So the optimal PEEP still may be even higher than what your inflection point. And so this is, maybe we're getting into another PEEP titration topic, but for people that use pressure volume curves and look at lower inflection points, just keep in mind you are finding the minimum PEEP that should be set on that patient, but it might not be a PEEP that optimizes recruitment at the same time of minimizing overdistension. So you may still find that a different PEEP level is beneficial, but it will likely be higher than your inflection point rather than lower.
Great. So that's really important. And let's just hit that because that was a point we were going to get to. So since we're on it, let's just talk a little bit about it. So when you said you can check for airway closure, how do you do that? How do you check for airway closure?
So one of the easiest ways is if you have a ventilator that has a slow flow inflation maneuver. For example, the Drager ventilators, they typically have this slow flow inflation maneuver. You can set the flow at 5. You can set you do the maneuver. You go into your maneuvers. You do a pressure volume curve maneuver. You set your flow at 5 liters per minute of flow. So it's very slow flow inflation. And then you can set, I believe you can set maximum pressures. You tell how much tidal volume to deliver. And really, any tidal volume is going to be fine, because if you're below airway closure, you're not getting much volume in anyway. So typically I'll set a volume that I know is safe for the patient. So in many patients, I would just set 3 or 350 mils for the maneuver, because I know that if they're getting 300 mils in the lung, we're definitely past airway closure, because we're getting closer to physiological values. But if they do have a really stiff lung, again, you don't have to worry about overdistension if you're just using 300 mils. So anyways, it delivers 300 mils at 5 liters per minute of flow. And then you will, if you have airway closure of any degree, you will have a lower inflection point. And this is typically what we've learned is lower inflection point is the point of recruitment or lung opening. And we're just finding that it's more likely airway issues rather than an optimal setting for the lung. But that's one way. It will tell you if you have an inflection point, that's essentially telling you have airway closure. In many patients, even ARDS patients, when you do these slow flow inflation maneuvers, and I should have added starting from a low PEEP. You start from your lowest clinical PEEP that you would use. In studies, they'll go all the way to 0, but even the people that have published those studies say just start at your lowest clinical setting, which is typically 5. If you go at 5, many ARDS patients won't have any inflection, and you think, oh, does this mean they don't have any recruitment potential? No, it just means they don't have airway closure. Where their optimal PEEP level and recruitment, obviously the lungs are opening, but it doesn't mean that they're open because you don't see an inflection point. So that's one method. That's if you have the tools. The Hamilton ventilators have a PV tool, but it increments pressure by 2 to 3 centimeters of water. So you may miss the accuracy of where airway closure is occurring because it jumps up in 2 to 3 centimeter water increments. So you'll still see an inflection, but where the actual airway closure is complicated and can make driving pressure calculations a little bit more complicated unless you're ventilating above the inflection point, and then you're fine. But really the easiest way every ventilator has it is just using volume assist control settings to read the pressure time curve. So you set volume control 300 mils, PEEP of 5, a rate of 5, you want very slow rate, and then you adjust either the flow or the I time, whatever your ventilator allows, to give you a flow of 5 liters per minute of flow. And then as the ventilator is delivering that breath, you will see the pressure time curve will increase, and it's either going to be linear or it's going to have an inflection point. And if it has a very significant inflection point, you just freeze your waveform, move your cursor over, and that tells you where your airway closure is. It's a complicated subject. Maybe we can go, your listeners can go listen to Brandon's podcast, which probably wasn't any less complicated than what I just explained. It's really more of a visual thing. I do have a number of videos showing how to do this maneuver on an online calculator that I have. It's called respiratorycalc.com. A shorter URL for that is rtmaven.com. Or you can check out the blog, the Center of Excellence in Mechanical Ventilation, COEMV.blog. And there's a link to my calculator on that page as well. And then you'll see videos under the recruitment to inflation ratio tab.
Great.
Yeah, I mean, the basic gist is that you want to see the change in perceived compliance during inspiration. And usually that's hard because the pressure the ventilator sees is, of course,
happening so
combination of the lung compliance and the resistance to airflow. But if we slow the flow down to it's very slow, then the resistance to flow is minimal. So most of the pressure we see is from the lungs. And that just means you got to get a very, a slow respiratory rate so you don't stack the breaths. And of course, the patient has to tolerate all this. But during that inspiration, you should have a constant compliance. And if it at some point drops, it must be because you opened something. And again, we used to think that was the alveoli, but perhaps it's the airways. And Tom, I think it's fair to say that airway closure is probably generally a more abrupt inflection than lung recruitment. It's usually a pretty clear angle.
Yeah. So generally, if you have severe airway closure involving multiple regions, it's a very abrupt, almost like a hockey stick when you look at the curve. Having said that, since our last meeting, there was a nice EIT study published by Laurent Burchard's group showing the progressive, so a more mild inflection point, which we usually see when we did pressure volume curves. But what they did is they measured these progressive curves with electrical impedance tomography in patients and found that it was in fact airway closure, but it varied region to region. So the inflection point was representing the lowest, essentially the lower of the, I believe, I have to double check now, that it was representing more of the lower end of the inflection curve, like the airway closures throughout the lung. But the differences could be, on average, I think 3 centimeters of water was the average difference between regions of airway closure. When you have a very abrupt, very obvious one, then all of the regions were very similar in airway closure. So it was telling you where the airway closure was, and it was pretty profound, throughout the lung. All regions were very, very close. But for those mild inflection points, it just was telling you that it's still representing airway closure, but of varying degrees throughout the lungs, which makes sense. ARDS is so heterogeneous. So you're either going to have no airway closure, you're going to have airway closure that's sort of uneven throughout the lung, and then you're going to have very clear airway closure, which is the inflection point is undeniable.
Yeah. And airway closure is probably a bigger topic, but if anyone's going to care, the two reasons are, one is that cyclic opening and closing of the airways may predispose to lung injury, just like cyclic opening and closing of the alveoli, but also because if you're trying to use compliance as a marker, it's not doing what you think if there's airway closure. Because if you're going from a PEEP from 5 to 10 and the airways are closed below a PEEP of 12, you haven't done anything to the alveoli. The pressure has not reached them. So it's just making more accurate your sense of the compliance.
Yeah.
And driving pressure. There's a huge interest in driving pressure. And if you're measuring driving pressure, you really should be looking at airway closure. Otherwise, you could be documenting extremely inaccurate driving pressures.
All right. Great points. Let's talk about esophageal manometry. So this is using an esophageal balloon to measure or try to approximate pleural pressure. Is that useful? Why do we do it? What do you think?
I can pipe in on this one.
Yeah, you have to have it, which I've never been anywhere that had.
You have to have it, do it, have experience. Yeah.
It makes the most sense for bigger patients when there's obesity, because so much of the pressure that we're measuring is extra pulmonary. It's from outside the lungs, which is totally different from pressure perceived just because of these issues of de-recruitment and so on. If you have a massive weight on the chest, you may have a huge airway pressure, but the transpulmonary pressure that's stressing the alveoli may be, normal. So I think there's a huge benefit there, because you may need a lot of PEEP just to get these patients to kind of their normal, leveled out, pulmonary gradients. Beyond that, titrating to kind of their lung disease, it's not as clear to me. But Tommy, I think you have more clinical experience with.
Yeah, so after decremental PEEP trial, my obsession definitely moved on to esophageal pressure. My very first publication in 2011 was a case report written with one of my first mentors, an ICU physician I worked with, Deborah Cook. It was my first ever case report. She encouraged me to write it up, and it was a patient that had intra-abdominal compartment syndrome. She wasn't obese, but she had like a rock hard abdomen. We had a heck of a time ventilating her. She was on 100% FiO2 and PEEP of 16. Like we had already increased the PEEP to, what we considered high levels. She was satting 85 for like an hour. We, called the OR. They're like, we're not touching her if she's on 100% satting 85. You got to sort that out, and then we'll come and see her. Like they didn't even want to come and consult at the bedside. They were just like, no, we're not going anywhere near that patient. So anyways, I convinced Dr. Cook to let me put an esophageal balloon catheter in, and it was very early in my understanding of it, but I understood it enough. I read a lot of papers. We put this catheter in, and it suggested we turn the PEEP up to 32 centimeters of water, which neither of us had ever seen in our career up until that point. And she actually said, okay, do it. She's like, I'm right here. If something happens, then we're all here. We'll figure it out. So I wasn't sure if my ventilator was going to blow up. I slowly went up on the PEEP. I got to a PEEP of 32, and I kid you not, we all just watched this. So the blood pressure was rock solid. It didn't change at all, which tells you so much about what's causing blood pressure issues. Like if you're not distending your lungs, the lung is not the problem, right? So we often think of PEEP as, you're going to drop your pressure if you actually are distending the lung. But as we increase PEEP, this patient was actually recruiting, and the saturation was going up. And again, I mentioned earlier, saturation is not the best indicator, but blood pressure was stable. Sats increased. Within 6 hours, she's on like 40% FiO2, and like within a day, PF ratio is over 300. So once we sorted her out, the OR came, the team came to assess her and basically realized, we could probably tap her abdomen here at the bedside. And as they tapped, I think they got at least 2 liters the first time. And as we're doing that, because we had esophageal pressure manometry, we could see the transpulmonary pressure changing, like basically going up, meaning your PEEP is now too high, as they were draining fluid from this lady's abdomen. So it allowed us real-time optimization of PEEP with transpulmonary pressure. So with experiences like that, I got really, really excited. The first EP-Vent study had been published that suggested benefit. A lot of the patients were abdominal patients in that study, which totally made sense from my experience at the time. But if we want to talk about evidence, fast forward, EP-Vent 2, they compared esophageal pressure guided manometry or mechanical ventilation against high PEEP table. They found no difference literally in any outcome with these patients between esophageal guided care versus standard with high PEEP table. A post-analysis did find that patients targeted within 0 to 2 centimeters of water of end expiratory transpulmonary pressure did have benefit compared to those that were outside of that range. And keeping in mind, even the esophageal balloon group had patients outside of that range because they used a transpulmonary table, FiO2 table. So the more FiO2 you're on, the more positive end expiratory transpulmonary pressure you would get, up to 6 centimeters of water. So they were admitting that going above 2 was too much. Keeping it within 2 was beneficial. They're now doing a third study. They're not calling it EP-Vent 3. I don't know if it's now a marketing thing because they don't want to keep adding on to but now it's called the Prevent-Villi study. And interestingly enough, they're only using esophageal pressure to set PEEP. They were also using it in the previous studies to determine lung stress and strain, which is even more complicated because of where the balloon is positioned in a patient. It doesn't represent the pressure in the open areas of the lung, the more ventral regions, right? It represents the dorsal lung regions, which is great for setting PEEP, but it underestimates the amount of strain put on the front of the chest or the baby lung. So in this new study, they're just using it to set PEEP, again, within, I think they're just targeting 0. And they're just using driving pressure as their indicator of whether or not ventilation is injurious. So rather than using a transpulmonary inspiratory pressure as a end all be all, they're just using driving pressure. So they're really moving away from the fact that driving pressure tells us a lot of information. And in fact, the hospital I used to work at, every patient with a PF ratio less than 200 got an esophageal balloon and got a full respiratory system mechanics workup. And what they found after publishing years of data was that driving pressure was just as helpful as indicating or identifying survivors and non-survivors as any measure of transpulmonary pressure related to lung stress and strain. So whether it was directly measured inspiratory transpulmonary pressure or the elastance-derived method, which better reflects the baby lung, driving pressure was just as good, if not better, to indicate potential for injury. So is there still use with esophageal pressure? I know I'm rambling now, but I believe so. And you kind of hinted at it, Brandon, but if you have an obese patient, I 100% believe that you should have, if you have a large obese population in your hospital, you should have esophageal balloon manometry available to you. You should train on how to use it. You will be shocked how different you manage obese patients after you start understanding it.
30 on that guy.
Exactly.
In any other method. Yeah. So.
Yeah. And I mean, that lady wasn't obese, but intra-abdominal hypertension, everyone gets a bad case once in a while, but we were also a bariatric center. So when I say that I had amazing experiences with esophageal balloon, that first one was intra-abdominal compartment syndrome. Every other like mind-blowing experience was an obese patient where we never would have gone to a PEEP of 20 or 22, shortly after getting a patient admitted to us. Like we'd have patients sent to us on PEEP of 12 doing horribly. We'd put a balloon in, put the PEEP to 24, and the patient's now on like 30% and like they don't have ARDS. But then the next question is, well, how do you wean the PEEP? Well, you fix what brought them there in the first place, like what's medically managed, then you just slowly decrease the PEEP. Once they start breathing spontaneously, they're going to help you with, maintaining lung mechanics and, maintaining an open lung. So you can titrate quite far. And then it's a matter of like, do you go all the way down to 5 or extubate these patients to non-invasive support? And that's typically what we did. We'd get down to a PEEP of anywhere between 10 and 14 on most of these obese patients and just extubate them to non-invasive. Once they could tolerate a CPAP of 14, we know we can do that off the vent. Like I can give you a CPAP of 14 with a mask and you're going to be fine.
Yeah. So this we see in the OR when we have really obese patients who are in steep Trendelenburg for, let's say, a robotic prostatectomy or robotic hysterectomy. And here we have both an obese patient, but also they're standing on their head and they have an insufflated abdomen. And so while we don't typically at our place put in an esophageal balloon, we know that if we did, the pleural pressure is quite high. And so the idea here is that, physics wise, everyone thinks that the pressure inside an airway is what matters. But of course it's not, right? It's the difference between the pressure on the inside and the pressure on the outside. And so I think in many ways, this is what you were just saying, Tom, if you're willing to go high enough on the PEEP, you could just look at driving pressure because you're going to minimize your driving pressure when your PEEP is appropriate. But you may need that help of that esophageal balloon to tell you, well, actually 30 is the right PEEP. Otherwise, you might not even be willing to get anywhere near that. So I think that's a
and to reassure you where your floor is, like maybe you don't need to go below 10 or 15 or whatever, because it's like that's their baseline now. You haven't even begun to grapple with their lung disease. That's sort of a whole nother matter. Right. But just to kind of get them to the same baseline all the people who don't have that extra weight on their chest have.
Absolutely.
Yeah, there's a number of studies done on patients, like healthy patients going in for surgery, and the average pleural pressure in a non-obese patient is around 6. So that would mean that setting a PEEP of 5 or 6, you're going to have 6 in the airway, 6 in the pleural pressure. You have a transpulmonary pressure at end exhalation of 0. This ideally is an open lung just based on pressures, right? The average pleural pressure in an obese patient was around 12. And I can tell you that most obese patients, again, historically, I mean, I've been an RT for over 20 years now. Historically, it didn't matter if you were obese or not. You were getting PEEPs of 5 or sometimes 0. It's like PEEP didn't matter. But the baseline PEEP just to keep an open lung in an obese patient is closer to 12. Now, we also did a study. My second publication I ever did was in, again, most of them were obese patients. They were in the OR. Many of them were Trendelenburg, and all of them were getting gastric insufflation. And we were comparing pleural pressures with abdominal pressures. And yeah, the minute you take an obese patient and inflate the abdomen, like the abdominal pressure is quite high and the pleural pressures are correlating that way, which means you are affecting lung mechanics and transpulmonary pressure. And there was a few times where I was in the OR doing these studies where I knew the anesthetist, and they were like, so what is all this stuff telling me? And I said, well, you see, I saw you keep going up on your pressure control and your FiO2 trying to get the volume. And I said, you might want to turn your PEEP up. And I told them, I'm like, according to the esophageal pressure right now, you might want a PEEP of like 12 or 14. And they were on a PEEP of 5, I think. And they're like, okay. And they're like, how will I know if it's good or bad? I'm like, well, chances are everything's just going to get better. You might have to turn down your pressure control after you turn your PEEP. And that's exactly what happened. As we turned the PEEP up, the tidal volumes got higher. They reduced the pressure control, turned the FiO2 down. Like I always say that if you're going to use esophageal pressure, when you start using it on an obese patient, it is like a magic trick. I would say 95% of the time, it's like you're performing magic. Like people usually like, oh my God, but then they look at the PEEP, they're like, what the hell do we do now that we're on a PEEP of 22, let's say, like in the ICU. And, you just to say, listen, let's fix the other problems and slowly wean them as they wake up. But right now, this patient no longer has ARDS and we're managing them with low FiO2 and let's move on from there.
Yeah. So you've mentioned EIT a lot. Let's talk about that. What is EIT and what does it help us do?
Sure. EIT, so E, electrical, I, impedance, T, tomography. So essentially it sends a small electrical current. It's so small it's not felt by the patient. It's like 7 to 9 milliamps. It's a very small electrical current. This does mean it shouldn't be used with like active pacemakers, for example, just because there's interference with the EIT signal. So your EIT signal may be affected. So it's an electrical signal sent through pairs of electrodes. So your device is either going to have 16 electrodes or 32, depending on the brand that you have. In terms of popular brands in the world, Palma Vista by Draeger has 16 electrodes. In the US, I think you only have the Timpel available to you, which has 32 leads. What it does is it injects this electrical signal from the first pairs of electrodes, and then it sends it to each pair of electrodes. So from, 16 and 1, let's say you had 16 and 1. It's going to send from 16 and 1, it's going to send that signal to 2 and 3, and 3 and 4, and 4 and 5, to each pair of electrode. And when it does that, it's measuring the impedance, which is just the resistance, and it's measuring the impedance of air. So in a breath, of course, the impedance of air is going to change drastically during inspiration, during expiration. So it sends this signal all the way around the chest once, and it gives you a tomographical slice. So you end up with an image of one time around the chest. But it goes around the chest 50 times per second. So this is why it can capture ventilation in real time, because as it's going 50 times around the chest in 1 second, it's showing you 50 images that it has taken while the patient is inspiring. So in 1 second, you have 50 images. It's like a cartoon, right? It changes. So it's like you have a video on the screen, but it's just 50 images being shown to you in succession. So it just looks like a video. And it's just showing you the distribution of this impedance, which is just the tidal volume changes throughout the lungs. So you can narrow it down into quadrants or layers. You can show anterior, posterior, and it just shows you where the volume is going. How this is utilized for PEEP titration typically is something that is coined the Costa approach, just because this was the first person to describe this method in a study that was in the Blue Journal. It literally had 2 patients in it. It was just describing the method. It wasn't like a randomized trial. So it's a widely used tool, but it's based on a case report of 2 patients just saying, look at what this told us. So now we're trying to study whether this is the optimal thing to do. But what it does is it has you do a decremental PEEP trial, just as we mentioned before. You start high, and then you go down to the lowest PEEP level. And at each level, it measures the change in impedance that occurs. If you have a device that it also knows the pressure, it basically calculates compliance of each region of the lung as well as your total respiratory system compliance. And when it's measuring the regional changes, it shows you changes that are worse, have worse compliance at high PEEP, and the areas that have worse compliance at low PEEP. So as you titrate the PEEP, when you're done, it analyzes each step and then gives you basically a crisscross. It shows you compliance that was zero. Again, compliance loss was 0 at the lowest PEEP, even though there could be overdistension. It just each range gives you a 0 reference point. So at the lowest PEEP, there's 0 overdistension, but on the highest PEEP, it tells you how much loss of compliance there was regionally at the higher PEEP level. So that's one line. The other line is at the highest PEEP level, they say there's 0 collapse. Again, not exactly true, but that's the reference point. And then as you decrease PEEP, it's areas of the lung that lost compliance as you decrease PEEP. So that's considered collapse. So it takes overdistension and collapse and maps it out. And then we think that the crossing point is the optimal compromise between overdistension and collapse. Now, there's people out there that I think we're still studying which is the best part. Is it, do we compromise completely and find the crossing point, or do we go where there's a little bit of more collapse but less overdistension, or do we allow a little bit more overdistension with a little less collapse? We're still not entirely certain. I believe some animal studies have looked at the crossing point is ideal. But the original paper, the two patients, they actually, their optimal PEEP was where there was less than 10% collapse. So they weren't using the crossing point. They were actually going by the amount of collapse. But this is what EIT does. Essentially, it shows you distribution of ventilation and it calculates regional compliance. And so if you have changes in PEEP, it can measure the changes in regional compliance. One of the things I used to utilize it clinically a lot was just assessing the response to PEEP. So as Brandon mentioned earlier, he'll increase PEEP more quickly, like in increments. So typically what I would do, this was my first thing I would do, I'd put EIT on a patient, and let's say their clinical PEEP level is 10, just for easy math. I would increase the PEEP while I'm measuring with EIT, increase the PEEP by 4 for at least 2 minutes, and then increase by 4 again. So at least 2 steps of 4. And then if they're tolerating it, maybe one more step. It depends. So I may get to 22 centimeters of water, but at least 2 steps, I would try to increase PEEP by 4. So they get at least 8 centimeters of water increase. Then I would go back to clinical settings while I analyze the data that the EIT is telling me. And EIT can show you the compliance improvements and the compliance loss comparing 2 PEEP levels. So I would compare 10 with 18. Let's say I went 14 and then 18. I would compare 10 and 18. And there's going to be a degree of compliance win and a degree of compliance loss. And then basically it's looking at, if I have a patient with a lot of compliance win and very little compliance loss, this is a PEEP responder. This is someone who I've just improved compliance in the dorsal lung region. Again, usually the regional improvements, it'll show you where they are, and it gives you a huge indication of how this patient responds to it. In some patients, there's minimal compliance win in the dorsal lung regions and a significant compliance loss in the ventral lung regions. And in those patients, they're not PEEP responders, and those are patients that I would almost immediately suggest we prone. Rather than trying to optimize PEEP, because that's one way to recruit an area that won't respond to PEEP. You prone them, you'd be surprised what that region will then start to respond to PEEP over time.
And is there any way to get a feel for perfusion? In other words, if you're seeing ventilation, can you also see perfusion and try to match those up, or no? All you're getting is the ventilation.
So with some devices, so not all the devices have that commercially available. I don't know if perfusion is available. So right now, the Timpel in the United States, I do believe even the crossing point software still has to get approved. So it's there. We've used it.
They do have. They just showed me at SCCM. You can use it.
Okay, so they're finally
or something. Yeah, it's ridiculous. Yeah.
So the perfusion, the Timpel does have it. Now, how you do it essentially is you have to stop ventilation for at least 10 seconds while you instill hypertonic saline. So you instill hypertonic saline. You either do the pause or you instill, I can't remember, but they have to be very close together because obviously you're going to start perfusing that immediately. So you want to eliminate ventilation. So it's only measuring the change of impedance based on the hypertonic saline, and it's not confused by ventilation. So once that 10 seconds is up, then you resume ventilation, and then depending on the software available to you, you can map out the ventilation regions with the perfusion regions. Typically on the bedside, it'll show you a perfusion map, and then you can view the ventilation maps. In most studies, they overlap them so that they have a nice graph showing you the VQ matching within the lungs. So we're moving towards some significant precision medicine. The question is whether or not that allows us to optimize patients in a way that changes outcome is sort of the next answer, but it's really fascinating stuff. So perfusion has been available for quite a while with the Timpel device. I do know the Drager device is working on it because I see it in publications, but it's not available commercially. But when I see it in a publication, I'm like, it's there. I know they have research software. Clearly it works. When is it coming to market? Because in Canada, the commercially available one here in Canada is the Drager one. We can use the Timpel for research only, but it's not commercially available. So I really want the Palma Vista, the Drager one, to have the perfusion commercially available because there's a number of hospitals in Canada that have that device that could really utilize that therapy and likely publish some nice research with it.
Well, that's what I find interesting about EIT. Unlike most of these other techniques that are lumping the whole lung together, it starts to allow you to be more heterogeneous and see how individual portions of the lung respond to certain things, not just geographically, but also even over time during the breath. Are there changes in inflation during the period of inspiration and things like pendula flow that are occurring that you would have no idea because everything else was like, oh, what does the lung look like at the end of inspiration? And that's that. So I think still an evolving area, but super interesting.
Very
right now it's the cost. It's just quite cost prohibitive. That's all. Like the device costs more than a standard ventilator, right? Yeah. So if you're a hospital and you're low on ventilators, you're likely not going to be buying any EIT devices. You're going to put that money towards another ventilator. Generally, the best time to get one. In Canada, not the easiest thing, but the best time to get one is if your hospital was buying a fleet of ventilators. You'd be like, okay, well, since we're spending this much, let's just add the Palma Vista. But whereas like the Timpel, despite it being the one available in the US, it has a disadvantage that it's not made by a popular ventilator company. So it's not like you can just squeeze it into so it's not like a typical add-on. You're like, well, we're buying 40 ventilators. Like, can we get this at a discounted price or whatever? Like they're a standalone company. So you're not going to get those types of deals. So most people that have it in the US are likely using it for research purposes, or they just have a really motivated department that went ahead and put the money towards it.
Now you can do a bit of this with other tools, right? You send the patient for a CT of their chest and you have a snapshot of their regional recruitment. You can do ultrasound if you're good at that. But these are, they're not as real time. How often are you going to do them? Can you really ultrasound their posterior lung and things like that? So, they all can kind of play a role. I think CT can really say a lot about where this patient's disease is right now. Is it very regional? Things like that. But you're not going to change their PEEP and then scan them again unless you're doing a trial. So,
well, I'm sure
unless you're from Italy. I was going to say unless you're from Italy. Gattinoni used to rest in peace, but like a lot of his studies were like CT study. Like it made it sound like he had a CT scanner in the ICU because every ARDS study has we have CT scans, and it's just like we don't do them that routinely.
Well, I'm sure we're going to see a lot more on EIT and some of this other stuff, and as EIT cost comes down and more research comes out. But this has been fabulous. We've covered so much great stuff. Let's go to the portion of our show where we make random recommendations. Do you guys have something you would recommend the audience check out for fun? Brandon, how about you?
Oh, for fun. Sleeping. Have you tried that? We recently had another kid, so I'm exploring the fascinating benefits of actually sleeping for a full night. As I get older, I think that's one of my favorite hobbies, actually.
Me too. Do you use any apps, white noise? What helps you sleep?
Oh, I'm all about it. Earplugs. We have a noise machine and an eye mask, and then we have blackout shades too. So
love it.
My goal is to just be able to hear if the children are dying.
Sounds about right. That's exactly what we always did. My kids are at the point where they sleep in past noon if I don't wake them up. If someone doesn't wake them up. So yeah, they're a little older now. No. So, I mean, I guess for fun, if you live in an area that has water, accessible water, whether for boating or swimming, look and see if anyone local, provides lessons with electric hydrofoil boards. Super fun. I do it. I have my own, e-foil board and, it's getting warm enough. I mean, we're in Canada, the water's freezing, but I have a number of wetsuits. But once it gets to a certain temperature, I'm willing to go out in the cold water. But just if you haven't seen them before, just Google electric hydrofoil and watch some videos. And most people, if there's a rep in an area where you live, usually people offer lessons. They're not cheap. They're cheaper in Canada. So if you come to Canada, hit me up if you're coming to the Ontario region, Kingston, Ontario. But otherwise, the lessons are quite expensive, but it's definitely a thrill. You're basically floating above the water. If you can pick it up quick enough, the lessons are typically an hour, and usually within an hour, I give lessons with a friend of mine, and usually within an hour, people experience the hovering above the water. So it's like riding a magic carpet ride above the water. It's pretty fun.
Very cool.
I highly recommend it.
That sounds awesome. I am going to recommend a recent interview Peter Attia did on his podcast, The Drive, with Sean Mackey, who's a anesthesiologist and pain physician at Stanford. And it was really a great overview of kind of the chronic pain in general, and then some of the newer things that are emerging about how we're thinking about chronic pain and some of the emerging treatments and a more holistic approach to thinking about pain in general and chronic pain. So I thought it was a really nice interview, and I would recommend checking that out. That's Dr. Sean Mackey on Peter Attia's podcast, The Drive. All right.
See, I didn't think you meant serious fun. I thought you meant like fun.
No, I did mean fun. This is just is just something I've gone through so many of the books and movies I've seen recently that I was down to this podcast. I wanted to shout out, but no, you guys did much better. I mean, it's hard to beat sleep, so I think Brandon takes the cake.
Yeah, fair enough. If I had to choose sleep over e-foiling, most times I would choose sleep too.
100%. All right, guys, thank you so much. This has been great. Thanks for coming on.
Thanks.
Thank you very much for having us.
Hey. If you are a fan of the show, you can follow us. We're on Twitter, we are on Facebook, we are on Reddit, and we are on Instagram. I'm at Jay Wolpaw on Twitter, and we're at ACCRAC Podcast, and you can find us on all those other platforms as well. If you are a fan of the show, please consider going to Apple Podcasts or wherever you get your podcasts and leaving a comment and a rating. It really helps others find the show. If you'd like to support the making of the show, please consider going to patreon.com/ACCRAC. That's patreon.com/ACCRAC, where you can become a patron of the show. Even if it's just $1 or $2 that you pledge, it makes a big difference, and we really appreciate it. You can also make donations anytime by going to paypal.me/ACCRAC or looking up Jay Wolpaw on Venmo. Thank you so much to those who have already made donations and become patrons. We really appreciate it. Thanks, as always, to our fantastic ACCRAC crew. Sonia Amanat is our tech lead, Taylor Duggan is our social media manager, and William Mao is our production assistant. Thanks so much for all you do. Our original ACCRAC music is by Dr. Dennis Quo. You can check out his website at studymusicproject.com. All right, that is it for today for the ACCRAC podcast. I'm Jed Wolpaw. Thanks for listening. Remember, what you're doing out there every day is really important and valued.